So we are, by the way, we're on LinkedIn Live. This will go on YouTube. So welcome everybody. It is April 11th, 2025. This is the Florida EMS webinar, where for the past probably 4 years, maybe 5 years, we've been doing weekly webinars. We bring the best and the brightest onto this webinar with bleeding edge EMS topics. And today is a very popular one because it's something that we don't really do and see frequently. We have a very close friend of the pod here, Dr. Casey Patrick, who's been on this webinar multiple times. I just saw somebody who said, "Oh, Casey is amazing. We've ripped off a lot of things from them in the past," and that is certainly true. Al, welcome as well to the webinar. So I'm going to pass it over to you guys if you want to make any further introductions, but we're excited to hear the topic and the paper. So guys, take it away.
Thank you, Peter. When y'all reached out to me regarding this paper, I was really excited to talk about it just because from a core medical direction standpoint, looking at our surgical airways over a 10-year time period, this wasn't a lot of fancy stats. It wasn't big numbers. There wasn't R or STATA or other things involved here. This really was the sickest of sick patients that we had in Montgomery County, north of Houston. For those of y'all who don't know, I am the medical director for MCHD EMS north of Houston, and we looked at 10 years worth of surgical airways. Now, the catch was during this time period, I was transitioning into the medical director role from Rob Dixon, who's since retired and is probably riding his bike somewhere beautiful right now. And I was lucky enough to have some amazing help from Al Lulla. And so I will let Al introduce himself. Al dug into this data. We worked on this together, but we could have never gotten it done without
Al. Yeah, thanks, Casey. So, not a lot of data out there about how we perform surgical airways in ground-based EMS systems. A lot of the data that we looked at as part of our literature review, a lot of it was in sort of dealt with more critical care transport type scenarios and some really high functioning systems. And so we wanted to see sort of in this ground-based service what we were doing with surgical airway. Again, we say that it's a halo procedure, right? So high acuity, low occurrence requires a lot of really extensive training, quality assurance, quality improvement, which Casey and his team really did a great job of, and we sort of wanted to dive into the data over that 10-year period. As expected, I guess I'll start with the limitations. With a study like this, we're not going to have huge sample sizes. In fact, I would say if we had huge sample sizes, I would be a little concerned about, how many surgical airways we're doing. So I was actually pleased that we didn't have to do as many surgical airways. Which is also, I think, a testament to improved sort of primary airway management skills, right? This is sort of a backup, sort of a secondary thing. And with the improvement in supraglottic devices and intubation skills and video and all that other stuff, I suspect that people are doing this less. But we ended up having 31 patients. And again, I just got the abstract pulled up. We can dive a little bit more into the data. We found that 42%, so 13 patients, it happened in trauma, while 18 patients were medical calls. One of the things that we were really interested in and wanted to look at is how long is it taking folks to do this procedure? We do not want to put folks in a place where we're doing multiple intubation attempts and then we're kind of at the end of the road, and that's when we decide to do a surgical airway. And what we found is that sometimes people ended up having to do 1 or 2 attempts. I suspect this is changing, and we've moved more towards drop an eye gel. If you can't ventilate them, move quickly to surgical airway as opposed to doing multiple sort of intubation attempts. So that's sort of the kind of data that we looked at. We also kind of looked at, the indications why people had required this. A lot of times it was related to trauma, foreign body obstructions, sort of the run-of-the-mill things that you would expect. We'll go to our table 1 here just to sort of give you a sense of the data. Overall, we used end-tidal CO2 as a marker of success. And what we found in this study is that we were 94% of the time we were successful. So 29 out of 31 subjects in the study had confirmed end-tidal CO2, which I think speaks to how well we can train these folks and how successful we can be doing this procedure. And people should be empowered doing it in the right scenarios for the right patient. Casey, I'm going to let you chime in. I just tried to give sort of the bird's eye view of what we did.
Yeah, there was when we decided to pull this, I don't know that we knew what the answer was going to be. So finding out first and foremost that we had positive end-tidal in a high number of these cases, from just a medical director standpoint, it blew me away. I don't think I would have said it would have been 29 out of 31. I would have probably gone a tad lower. So that is number one, probably the most relieving and encouraging part of the study. I will say, just for those of y'all who are listening and haven't read this or watching, we use and have taught scalpel finger bougie technique at MCHD throughout this period. This wasn't a kit or a complicated tracheal hook situation. This is a scalpel, your finger, and a bougie with a 6.0 tube and end-tidal waveform. And we taught waveform capnography for confirmation, just like we would for a standard or a tracheal endotracheal situation. So what Al did was dig through those charts and look for evidence of positive waveform, and those were successful. The ones that had no waveform capnography were not. Lots of questions have been asked to us after the fact about survival rates and hospital outcomes, and some of the things that we would all want to know if we lived in a perfect world. We did not have, especially over a 10-year time period, we did not have access to that. So we can't really speak to morbidity and mortality per se, more towards just, can paramedics be trained to put the endotracheal tube through the cricothyroid membrane into the airway in the field in these high risk, low frequency situations? And our answer to that question is yes. The other elephant in the room is, timing of this, and was this the right time? Were we too slow? Were we too quick? And as we all know, that question is really difficult to answer, and it takes a case-by-case assessment really to get there. So we didn't precisely try to answer that question as well, because that's something that, as we all do, everyone on this call that's got an adjacent or direct medical direction role, if you have a surgical airway in your service, you're talking about that a few minutes afterwards most of the time, and then for the next several days in a row, trying to figure out whether or not this was good, bad, ugly, or all the above. And most of the time, honestly, when we get to that surgical airway situation, it usually is some combination of those things. But to know that we can train and we can accurately hit our mark, and to get some idea of who these players are going to be, because the other piece, to Al's point on, these were the patients that we would have expected to get surgical airways, trismus, foreign body obstruction, massive facial trauma. I believe if you had given me a multiple choice beforehand, I would have picked those as the top three. And so really that allows us to teach that even more firmly, as far as, hey, if you see massive facial trauma, if you have trismus that you can't overcome, if you have massive facial trauma, choking on a big piece of steak that you can't remove, those are the situations we're going to have to go maybe from Cric plan C up to plan B or plan A, without those 6-7 intubation attempts that I was discussing.
Yeah, and the other thing I just want to add on to this, a lot of these patients were in cardiac arrest. I think that just goes to show sort of the acuity that you're dealing with a lot of these patients that are requiring surgical airway. So I don't think we really anticipated folks necessarily were going to have great outcomes in terms of neuro intact survival. Yeah, I think our study had upwards of 84% of the patients were in cardiac arrest, whether from trauma or medical. Some of the other data that we looked at when we were writing this paper showed that, other studies have quoted upwards of 60, 70%, depending on the study. So, again, with small sample sizes, I don't know how much stock we can put into that, but it's just something that I thought was interesting.
Excellent. Casey or Al, would you mind discussing the type of training, not exactly how you do it, but the frequency and the cadence by which you guys are doing this training?
Yeah, I can speak to that one. And that one it's a lift every year. And it's evolved over the 10 years. It hasn't been exactly the same over the 10 years. Um, we've had some pig labs in the distant past. We've moved away from those to cadaver labs. We also have tissue trainers next that we use. But everyone who does surgical crike, who's credentialed for surgical crike in the service, and this is not all of our providers, this is not all paramedics, this is our in-charge subset and above. So out of our 350, this is probably somewhere about a third of those or less. So it's at least a less unwieldy number, and they're required to undergo for high frequency, or excuse me, low frequency, high risk skills training every year. So the goal, and I can't say, with supply chain and COVID and everything that's happened over the last 5 to 10 years in there, we aim for cadaver training yearly on this with augmented model training in the interim.
Nice, that's amazing.
We've not been perfect there, but we're pretty close.
The other question I have, and it just relates to a friend of mine who called me up last year and said that as soon as they did the training, the number of surgical crikes spiked. And I wonder if you saw that same effect.
Honestly, surgical airway's been in the service longer than me. I started at MCHD in 2015, and our data here stretches back to 2012. So historically, I don't know the exact timing as far as introduction of surgical airway into the service. It's just been there since I've been there. Our frequency over my tenure there has been relatively stable. We average about 3 a year. And with our intubation attempts numbering between 300 and 400, that puts us right in that 1% range, which is where the near database would suggest we have to crack people in the ED. So we feel like it's pretty reasonable. And like I said before, all of these get a microscope in real time and then some. Have some of these been questionable? Absolutely. It's EMS, it's medical direction. These are tough decisions. Have some of these required lots of discussion, and could you have done it sooner? That in the ones that I've reviewed during our time, that's been a question. Were you late on this? That's been a question. So the exact timing and the exact details are always murky at best.
I want to get Dr. Lee in, but my other question as a follow-up is, have you ever received like massive pushback from the ED when you get there, second guessing you, doing evaluations afterwards, getting you into meetings, second guessing any of these calls, or have they all been pretty straightforward?
I mean, I don't want to say all of them have been straightforward. I think anytime we bring in a surgical airway to the ED, it raises their, level of concern, their level of, oh, really? I will say that we have great relationships we have 3 level 2 trauma centers in the county. We have great relationships with all 3 of those. So the hospital feedback side of it is very open and a two-way street, thankfully. We also have really good relationships with the medical examiner for confirmation, on the unfortunate ones that end up in an autopsy situation. So I don't remember any massive dust ups in the time that I've been here. I can't say that I reviewed every single one of these. Some of these ended up with Dr. Dixon during that time period. And then some of these are pre both of us. So I imagine that there were some that had questions. There's no doubt about that. But as far as massive, no, not that I recall.
Excellent. Let me bring in Dr. Wayne Lee. Dr. Lee, how are you? Come on in, ask a question, please.
Hey, good morning. Good morning. I'm not sure that my thoughts are in any order or that they're particularly useful. However, it's kind of interesting looking. I see there are 39 people on this, and you know, we'll see your calls, Peter, where we'll have this big a number, but I think it sort of validates how how interested we all are in this particular item. Now, you know, I've been a medical director for a long time. I used to have 7 fire rescue systems. And I wasn't, you know, and so each one of those, we might have a cric attempt, and this is in the early days. We might have a cric attempt every 1 or 2 years. And but the advantage of having 7 cities was that I saw 7 cric attempts in a year, you know, and I realized that first of all, one of the problems we had is that our cric kit was actually the blade in the OB kit, and so we had to go open up the OB kit, and
Mm-hmm.
now
Yep.
this goes way back, you know, so I'll try not to. But at any rate, and so then I began to think about equipment, et cetera, and making it easy, et cetera. I do like the simple technique. I always have liked a trach hook, but I do think that a blade and a finger, et cetera. The thing that, and I used to do a pig lab also with my medics, and when I did it, it was just when I was, you know, when the bougie was coming back around. You know, the bougie had been in place years ago, and then we stopped using it. And then it showed up as a flex guide and in the airway course and so on and so forth. And so everybody began to have a bougie. But when I did the pig lab, I realized watching people that they couldn't get the tube in, you know, and only then did I begin to teach the bougie is the trick. And so I believe very strongly about having a bougie readily available. And so you can almost go and have lunch once you get the bougie in, you know. And by the way, and the reason I'm talking about this is I had a case, a kid with a hot dog, and we actually, unfortunately, we got to see the autopsy on this child, and the incision was made correctly. It was perfect. The problem was we couldn't get the tube in, you know, and that was because of probably because of no trach hook, but it's certainly because of no bougie. And had we had the bougie, I'm convinced we would have gotten the trach in. So can't underestimate the bougie. The other thing is training. And I think training, and I think we all struggle with this, but you know, I tried, and I have to say, I don't think I'm particularly successful, but I tried. I don't believe that these critical procedures, I think if we could do it once a year, that might be okay. But the fact of the matter is, this stuff, you know, it gets forgotten very quickly. So one of the things I've tried to do is not to have it be a training program where there was a big drum roll and we had it, you know, once a year, but that the battalion chiefs do it on a local basis, on a more frequent basis, every 3 or 4 months. Now, I will say that hasn't been entirely successful, but at the same time, my point is that you can quite easily train this by grabbing another paramedic and laying them on the table and making sure, and
Yes.
they need to know, you know, where to do it and how to do it. You know, number one, they need to know what equipment that they have to do it with. They're very familiar with that. And they also need to know when to do it, which you've touched on already. And one of the cases, I did a lot of expert work for mostly defense, but I ended up doing a lot in EMS also. But one of the cases I had was actually an ER case, and it was an angioedema a patient. And the doc, they tried multiple times to intubate. They waited too long. The patient was hypoxic the whole time. And finally, they decided to do a cric, and it wasn't successful. They didn't have a bougie. It was just a disaster, you know. But you know, you can't intubate, you can't ventilate. It's not about intubation, it's about ventilation. But once you come to that point, you don't have it. It doesn't take very long to decide that it's time to go, you know. So it's really about
Mm-hmm.
ventilation. And so once you can't do that, you got to head for something else. And then lastly, I think. Oh, but I just want to emphasize the training. I think, and one of the things, I don't think we're fair to the paramedics. So all of my lieutenants, you know, could be faced with having to make this decision. I don't think it's fair to them to ever ask them to make this decision unless they have a high level of confidence that they can do this. And I think that the
Mm-hmm.
high level of confidence, it's an intimidating, they might be able to do it just fine, but if they don't have the confidence they can do it, and we can only get to that confidence level by by going over and over and over it again with them. And so what I want to happen when I go to my stations and I say, by the way, show me how to do a cric, that there is not a blink of the eye. Okay, here's the indication, here's the equipment we have, and this is how I'm going to do it. And I can lay somebody down on the table and demonstrate that. Enough said, but anyway, I really appreciate what you guys have done. I love this topic.
Great conversation. Go ahead, Casey.
I got two quick things on that. We found the same thing, so we created this very simple kit that has the scalpel and the 6.0, and the bougie is already in the Airway kit, but there is a red bag that's separate from everything else that's in the Airway bag that has those tools, so they're not digging in the OB kit or wherever else the scalpel may be. I don't remember when that happened in the time span of this study, but that exists now. And as far as mental reps, we preach that. I preach that. You're not going to get enough physical reps on this to be good at it. You have to do, every couple of weeks, every month, mental reps, and that's indications, contraindications, equipment needed, and then where do your hands go? And practicing on a partner or practicing on a mannequin, whichever one, any of those stepwise processes that you take are going to be better than not doing it at all. Is that as good as doing it on a human? Obviously, no. But I do that, regularly for my own emergency department practice because it's not like I'm out there doing a ton of these. So we really preach the value of mental reps and walking through it with your partner and talking through it, not just, oh, I probably should think about crics, but being intentional and talking through it as if you were, managing one on the scene. So agree 100% on all those points.
Excellent. And I want to go now to Jonathan, and Tan, I'm going to come to you next, just so you FYI. But Jonathan's a great friend. He's been on the podcast several times. He runs a large system in South Metro out in Denver. Jonathan, Dr. Applebaum, go ahead. Love to hear your question.
I was so excited to see this pop up as the topic. So I'm the person with the agency that we had a spike in our number of crics when we moved our program for training to be more aggressive with cadavers and such. But I had a handful of questions for you. With your algorithm for your medics, do you give them the leeway to go straight to cric when
Yes.
they're okay? Because that was something which we had incorporated as well, and we'd gotten some feedback or concern from the receiving facilities, like, well, they didn't even try. I was like, there's no point. Just you were looking at doing that. So I had a question there. Did you happen to, or were you able to record in the study the number of failed airways, patients who couldn't be intubated, maybe it wasn't one of your senior medics, they weren't cric'd in the field, and were transported with a suboptimal airway?
I can't imagine that number is a number that I would be warm and fuzzy to take a look at, but we know those are there. Yeah, for sure.
Yeah, because that was one thing which, because as our program moved forward, we took a lot of flack, a lot of feedback that was unconstructive, and so that was my comparison of, okay, well, where are we at in terms of airways that have not? So I was curious if you had that, and then last in your group, did you have any survivors?
We looked at just the EMS data. We didn't have hospital access, so I hope we did. But I mean, there was a large proportion that was in cardiac arrest. One of the larger EMS studies that's there was Marcolini, and it was early 2000s, and they had 2 of 61 with neuro intact survival. So I would suspect that number would be low. That's what the small but existing literature tells us. So
Yeah, no, I was just curious.
yeah,
Fantastic.
we just had EMS data, and we just pulled those who had surgical airway documented in the EMS chart. So as far as the misses, no, we didn't dig there. That'd be an excellent question to ask. And as far as survivors, we had EMS data only.
Fantastic. Well, thanks so much for doing this. I really appreciate it.
Al, did you want to make a comment before I go to David?
Well, I just wanted to say, in addition to and I think folks have sort of touched upon this, in addition to the psychomotor or the motor aspect of doing this procedure, it's sort of the cognitive aspect of it, I think, is an integral part of training, is empowering paramedics to feel like, hey, we need to make a decision, and we need to make that decision early, and also not making them feel like there's some sort of Monday morning quarterbacking, retribution, anything like that. I've had paramedics who have performed a surgical airway and definitely were questioned by it. And I think we've all been in that situation where somebody else has questioned what our decision was in a heated moment. And I think it's good for us in medical direction to support our medics through those challenging types of scenarios.
100%. And I'm going to bring in David Miramontes, runs a very small fire department in San Antonio. He actually, I'll teasing aside, but David, you put some links in the chat, and I'd love to hear your comment. Go ahead.
So if you can't intubate and you can't ventilate, you criculate. It's that simple. And we do the body lab every year for our guys. And I've been here 10 years. So it is a rare thing in our system. So we do about 600 calls a day, and we do one a month-ish. It's pretty rare. Believe it or not, a lot of times we do it is not trauma. It's at the jail because they have the massive sympathomimetic ingestion from a balloon or whatever, and they get trismus. So we see that many times at the jail, actually. So that's my thing. We use the device I put in the chat. So it's a bougie with the tube, and then it has wings that you can use sterile towel clips to clip onto the neck. So that's the best way to do it. We're not using the clips yet, but we're fixing to. But that's a good little device, and it's only $19. It's not expensive.
So
all they need is a scalpel and that.
I'm a really big fan of assessing a patient who you think is going to need to potentially be a difficult COCV type of situation, and doing a quick attempt at a supraglottic device. I mean, they're very quick. You're not in the airway for significant amount of time. You're not having significant worsening hypoxia. And I've had cases where we've had patients who had horrible angioedema, and the medics just put in an I-gel, and they were actually able to ventilate this patient, surprisingly. And then if you can't, you pull it out, and then you go to cric. I'm not a huge fan personally of doing a lot of intubation beforehand.
Excellent, great comment. So I'm gonna go now next to my co-host Tanner Smita, who I'm sure is chomping at the bit with all this research that I'm sure you have a lot of thoughts in your mind about these types of procedures and the research behind it. So Tanner, take it away.
Yes, thank you both for coming on to present. I have a couple questions for you. I'll give you them all at once. You can comment on whichever ones you want, if any. So first of all, I noticed that if I'm interpreting the chart correctly, the number one indication for cric in the study was trismus. And so I was wondering, was this before the introduction of paralytic assisted intubation to the system, or was this trismus that was unrelieved by paralytic administration? So that's my first one. My second comment, I really like that you reported the time to procedure stratified by whether intubation was attempted first versus not. And there was almost a 15-minute difference between those two groups of patients, which suggests, 15 minutes of perhaps suboptimal ventilation or perhaps no ventilation at all, which I think we can all assume could have a profound impact on patient outcomes. And so kind of springboarding off that, I was wondering, is there any kind of rule that you've presented to your providers is there a certain number of attempts after which they should proceed to cric if the supraglottic airway fails, or a number of minutes from the time of initiation of the first endotracheal intubation attempt? And then finally, so this is my third question, more related to the system in which I practice and do research in. So in West Virginia, recently surgical airways were introduced into the scope of practice of ground paramedics. And so along with that comes the problem of how do we train these people, particularly given the fact that West Virginia encompasses a lot of rural EMS systems that are poorly resourced. They don't have access to cadaver labs or animal labs. And so I was wondering, in your practice, and I guess this is an open question to everybody on the call, in terms of trainers that are available commercially, I know there's some 3D printed trainers out there. Are there any that are cost effective, inexpensive, that we can use to train these rural agencies that just simply don't have access to cadaver labs and more kind of advanced training?
I'll take the third one. It just popped up in the chat. There's a link to a relatively inexpensive trainer that's there. We have some 3D printed trachs that we have wrapped with, Coban and the like, and used for mental reps. I can't really say that I know what it would be like to manage a service with no access to cadaver labs, and then how you balance that risk benefit as far as, do you think that training's sufficient or not? I don't have the answer to that one. I think that's going to be an individual medical director feel based on, how well you think you can do using non-cadaver, less expensive methods, and whether or not you cost share or tag team on somebody else, coattail ride, whatever you may need to do. That's a decision that, thankfully, I'm lucky I have a supportive board, and that values training in the clinical side of this. So I'm thankful that I can answer that. As far as the paralytic question, I wish you had been a reviewer, because I don't know that we got asked that. I'll kick that one to Al. I know that we've had paralytic assisted intubations in the service through the duration of the study. I can say yes to that one. As far as these cases individually, and whether or not those got paralytics or not, in the relationship to trismus, that's a really good question that actually we probably should know the answer to, and I don't. So I'll just own that one. And then lastly, as far as putting exact time rails and time borders around this, or attempt borders, that always gets kicked around when you review these cases. Should we be more direct? Should we clarify more? And I just believe that each one of these situations, when you're talking about 2 or 3 a year in our service, we have about 100,000 calls a year, respond to about 70,000 plus or minus. So I believe they're individual situations. I think that if you try to say only after 2 attempts, you're going to find that one that needed it after 0. If you say, 10 minutes, you're going to find the one that the medic knew in 4 and is going to be standing there for 6 minutes waiting to clear your time hurdle. I believe this is such a complicated decision that those guardrails are going to limit you more than they're going to help you. There are others on this call that could absolutely have the other opinion and be totally valid. That's just my own personal opinion there. So, Al, paralytics, do you remember?
Yeah,
I don't. It's a good question.
So there were definitely a handful of cases where, especially for trismus, that paralytics were used. I think, as everybody on this call knows, paralytics are high risk, high reward, right? I mean, if you paralyze this person and now you're not able to secure the airway, you're basically guaranteeing yourself a cric at that point. So I think some folks are just a little bit more hesitant in these sort of potential COCB situations to paralyze. But for situations like trismus, we definitely had multiple cases where the medics did utilize paralytics, or Rob Dixon was on scene, and he assisted the paramedics with that portion of it. And that brings another component to this, is sort of what is our involvement with this procedure, in EMS medical direction in the field when it actually happens. So just more fodder for discussion, I guess.
And there definitely was, honestly, evolution of our system over this time. We currently teach first look, best look, and are very pro paralytic assisted intubation if we're going to look with a video laryngoscope. Some of the preliminary data from MedStar and the ED data suggests sedation only intubation is fraught with problems. So we don't teach that. So most of our crics now, I would say, would have probably received paralytics if they were going to be intubated. So we are a first look, best look, service with rocuronium. That the other side of this is there was about half of this study period that the paralytic would have been succinylcholine. So from a length of action standpoint, when you start to get into some of these times that we had to cric, they may have gotten sucks up front and then criced with trismus, and the sucks had worn off. So there's a lot of complexity there that could exist. This wasn't, this was a 10-year time with the service that evolved. So,
and Casey and Al, the question I have is, now that many of us have VL that's recorded, and we are now reviewing all of these, are you able to discern anything further from these cases now that you have the recordable VL, if that's indeed what you're doing?
I hope so. We have recordable VL that rolled out at MCHD 31 days ago, March 10th. So we've not had a cric. We've not had a cric yet, but we're reviewing 100% of our airways now with 100% feedback. So I can't help but think that when we see what's in the airway with the VL attempt, that we're not going to have at least something more to speak to in that run review. And I want to mention something that Al said that I'm not pushing back on you, Al, but I will say that, we do want to support our medics, but there is that fine line that we have to walk in these situations where, that some of that feedback may be next time, let's look at this data, let's look at this timing, and could we have pulled the trigger sooner? Did we pull it too late? That's such a tough space to be in when it's such an emotionally charged decision. And no, the medics do not want to get beat up, and I'm the last one that wants to beat them up. But we have had a couple of these in the service. I do remember, more than one where there were learning points and there were spots to improve. So that has to be timing. There has to be relationships built. You can't not know your medics and walk in and start talking about the cric intricacies and timing and them not be crushed if they don't know you're coming from a place of trust. So that's a tough piece. I think is worth mentioning.
Yeah, this turned out to be a masterclass here because we're getting a lot of great discussion after the paper was discussed. So we're going to head over to Dr. Pepe's webinar, but let me give you guys the last word, both Al and Casey. You have a lot of people in this webinar. Thousands will listen to it afterwards. What would you tell that agency who doesn't have the resources like Tana was mentioning, or hasn't done training in a while? What would be your final words to them here as we head over to Dr. Pepe's webinar? Casey, you want to go first, and then Al?
Sure. I would just say you have to dedicate time to teach the why, not just the how, because the why is infinitely more difficult than the how. And you have to make sure that, that the medics know that you have their back, and that everybody's on board with this being, one of the more high intensity, difficult, big ticket decisions that we make in all of emergency medicine. So I believe the why here, and I think our paper shows this, is we know that we can put the tube in the right place. The bigger question, and some of these questions after the fact, really hammer home that putting the tube through the neck we can do. How do we do it properly with the correct timing is still ripe for discussion and further research. And so I would just say make sure we focus on the why as much as the how.
Love it. It's all about relationships with your medics, and I love that comment. Thank you, Casey. Al, take us away.
Don't have much else to add, but I'll just say, in addition to the why is the when. We have to understand that our medics are in challenging situations with a lot of cognitive stressors. We've all heard the old adage, the hardest part about doing the cric is making the decision to do the cric. And so I think that's an important part of their training. What we know from just general airway data is that multiple intubation attempts leads to worse outcomes. I think if you're in a high functioning system and you have some good tools like VL and good airway training, I'm not going to frown upon anybody wanting to attempt to intubate somebody. But if it doesn't work, I think we have to sort of get the ball rolling quickly and make that cognitive jump to the next step. I think that's the piece that oftentimes is missed.
Beautifully said. This was a fantastic discussion, as Brett just commented in the chat. Thank you both. Thanks for contributing to the literature, as you always have done, and for spreading the knowledge by coming on to the webinar. I appreciate you guys. In the link, in the chat in the side is the link to Dr. Pepe's webinar, who's sitting right across the room from me here at FDIC in Indianapolis. Thank you guys so much. And Casey and Al, you guys are always welcome back on our podcast anytime. And we appreciate you guys. Thank you.
Thanks for having us. We appreciate y'all.
All right. Bye, everybody.